Hi, everyone. My name is John Fedota. I am a program officer in the Division of Neuroscience and Behavior at NIDA, and speaking on behalf of the planning committee for the HEAL recovery workshop that you all are participating in or observing. And I want to first of all thank everyone again for taking time out of your busy schedules to participate in this workshop. The first day of the meeting was on Wednesday. Many of you were there for that, and I thought it was a fantastic day. I mean, it was one of the more rewarding days that I've had in this job. Being a part of that session. We had a session on lived and living experience in recovery, which we've provided the recordings to the attendees at this point, and I encourage you to watch those recordings if you weren't there for the meeting, because it was a really powerful and informative session. And I wanted to thank again Jess and Noel for facilitating that discussion, along with Shelley Sue on our side, and for all the panelists. Thank you very much for your time and your candor, sharing your lived experience with us. The second session, on Wednesday, was on applied clinical experience, and Aaron and Mark led that one. I see Aaron's on now. I don't know if Mark's here, but that one was a fantastic extension of what we heard, and sort of talking about what information the clinicians need to do their job, and what are we doing in order to support individuals in recovery, in remission and recovery, and how can we as a research community provide information for the clinicians and for those working in treatment and peer support and other forms of treatment. How do we provide them with useful information and diagnostic information to support people as they go through recovery? Today, the discussion is going to be focused more on translational research. So, given the realities of recovery that we heard about on Wednesday, what can we now do to operationalize some of the things that we heard, either in more detail than we have previously, or are there new constructs or new ideas that we need to operationalize? So that's really the gist of the first discussion that Kelvin and Warren are going to be facilitating, along with Xiaobei Wang from our side. From the NIDA side. And then the second discussion, the last discussion of the meeting, is going to be more on measuring and modeling the constructs that we talk about. And Anna and Brenda have graciously agreed with Jenny to facilitate that discussion. So today, really, I want to encourage, we had a lot of back and forth, a lot of cross-pollination on day one, on Wednesday, and I really want to encourage that again today. I think both within the panelists for today, there's a lot to be shared in terms of what we're measuring and how to measure it. So there's, those are effectively the two questions. What should we measure and how should we measure it? And then for the panelists from day one, please speak up and please participate in this discussion. The goal here is not just to do research for research's sake, but to do it to close the loop between recovery and research. So what information is useful, and in the way that we're talking about modeling various constructs and ideas today, does this ring true? Does this align with the kind of stuff that we heard on Wednesday? And Jess Halsey, who was the one of the facilitators for the first session, has offered to be the voice of if the conversation goes too far down the technical jargon route. And so we've given her carte blanche to raise her hand at any point, and we can provide some more context for what we're talking about in order to engender this conversation and the back and forth between the various constituencies here. Because I think the important thing about this meeting, and it was proven out on Wednesday, or a unique feature here, is we've got expertise at every level of remission and recovery. We have people with lived experience in recovery. We have clinicians on the front lines of supporting that recovery. And today we're going to hear from researchers who are trying to understand the biological, environmental, and social and cognitive constructs associated with recovery, right? And there's a lot more. My takeaway from Wednesday was there's a lot more we can be doing, and there's a lot of additional sort of areas that we can look at. And I think Warren and Kelvin and Jabé will lead us in a discussion on that front shortly. But there's more we can do, and there's things that we heard on Wednesday that we don't spend a lot of time talking about on the research side, or we haven't to this point. And I think we now have the opportunity to start doing that. And just very briefly, for those of you who weren't here with us on Wednesday, one, you have the notes and the recordings of that day, and I do encourage you to spend some time watching those recordings. It will be a couple hours well spent to watch those discussions, and just the sort of general highlights, so we all start from the same page here. And anyone, of course, from any of the panels on Wednesday, please speak up if there's more context to add before we jump into the discussion here. But just the highlights that we sort of captured on our side were that recovery is a social construct, and it's defined by the individual, right? Like, recovery is not a stage, it's not a discrete process, and it means different things to different people. And I think it was really well said in the meeting that what it means is changes, right? And it's a more stable and happy life. And it really, at the lived experience level, I was struck by how much recovery focused on human flourishing and improving human flourishing. We spent a lot of time talking about the presence or absence of various compounds in biological samples. Unsurprisingly, that did not come up in the discussions, right? I think this supporting of human flourishing, Ashley had a really good point in our discussion about it, about, we're being instructed on the things to measure, and it's these, social support, recovery capital, and environmental factors. And another thing that came out in that discussion was that success in recovery is coping skills and resources, right? It's the ability to manage the challenges that come up in life. It isn't the presence or absence or a specific use pattern or a specific percentage in any biological samples, right? And it's a challenging process because those challenges and those resources are needed at multiple levels: social level, a physiological level. There's a stigma associated with recovery, whether you're in treatment or not. Oftentimes more in treatment than not, and that's something that I think we should talk about today. And basically that the idea of I want to be understood, not told what to do. I think that was one of the quotes, paraphrasing one of the quotes from one of our panelists, and that really struck me, right? Like, it's not that there's an answer that we need to seek, and then it's just a question of giving that answer to individuals. It's really starting with the individual's goals for recovery, and then the clinicians providing options, right? That was a main point of the second session, right? The patient provides the goals, what do they want out of recovery, and then the treatment support provides options to achieve those goals. And we want to create the right conditions and the right environment for recovery. And one of the discussions that we ended on Wednesday, and I think this is a good transition into the first session today, is this idea of recovery vital signs, right? So what are the measures what are the things we can collect that characterize this idea of human flourishing, or the idea of providing the resources, at multiple levels to deal with the challenges that come up as part of the process of recovery, and then what of those can we do in which context, right? So in a clinical visit, in an 8-minute clinical visit, there are certain things that you can and can't measure, but we have technologies that allow to characterize the environment and the social support and the sort of network that individuals are operating in at a much more fine-grained level, and not in a clinical setting. The majority of individuals in recovery did it outside of a treatment infrastructure, right? So we've got to come up with other ways to characterize the processes that we're interested in. We have to identify those processes, and then we have to come up with more creative and different ways to characterize them, right? We heard a lot about the importance of peer support, and so what can we measure in those kind of constructs? And I'll end with the most salient definition of the success of treatment that I heard was from Mark, who said, if they're showing up, that's success, right? It's engaging in a process. It's finding something that's that's relevant and useful and progressing for an individual. And I think that's much different than a semantic argument around a specific biomarker or anything like that. So with that, the way today is going to work is we've got a series of 2 90-minute discussions. The first one led by Kelvin and Warren and Jabe. Then we'll have a 15-minute break because I anticipate this one will be as mind-blowing as the ones on Wednesday. So, to collect your brain, put it back in your head. And we'll have another 90-minute session after that, led by Anna and Brenda and Jenny, talking about the modeling and measuring of these constructs. And then another 15-minute break. And then we have an hour at the end if there are, if the conversation goes in directions that we can't fit into the 90 minutes. That certainly happened last time on Wednesday, and there was a really fruitful discussion at the end. So I encourage you, to the degree that you're able, to stick it out till the end, because the conversation, the goal here is, again, not to have presentations. It's to have a wide-ranging discussion on this from multiple perspectives, right? So to the degree that everyone can leave their cameras on, that engenders that sort of discussion. To the degree that we call each other by our first names to sort of level the playing field here. Everyone has a valid perspective to provide here, and we want to make sure that works. Jess is going to help us out doing that, and then finally, just I encourage everyone to speak up in all the conversations. Just because you're a panelist on one doesn't mean that you're, you can only speak on that topic. I think the power here is in the consilience across the perspectives, right? The degree that we can sort of all be speaking the same language in terms of what we're trying to measure, and then figuring out if those measurements are useful or helpful or informative. So with that, hopefully that's the most that you will hear me talk today. And I'll hand it off to Jabe to start the first session. So 90 minutes here. We're going until, I wrote it down and now it's gone. 90 minutes from now.
Okay, and thank you, John. And hello, everyone. Thank you for joining us today. Firstly, I would like to express my gratitude to the panelists from session 1 and 2 for providing a very informative insight about the meaning of recovery. We learned a great deal from those discussions last Wednesday, and it will give us a lot to think about and build on. Now it's time for our session 3 panelists to introduce themselves. Would you please, I would kindly ask each panel to give a 1-minute introduction, starting with your name, affiliation, and interest in the topic. Just to introduce myself, I'm Jabe Wang at NIDA, the program officer of the Clinical Research Grant Branch at the Division of Therapeutics and the Medical Consequence. Our division is committed to research and development of therapeutic tools and options in order to help the people in the recovery journey. Now, I will turn to Warren Bickle to introduce himself. He is one of our co-facilitators today.
Thank you very much. It's very nice to be here. So I'm Warren Bickle. I direct the Addiction Recovery Research Center at the Fralin Biomedical Research Institute at Virginia Tech. I've been doing research on addiction since 1984. Since the mid-aughts, I've been very interested in recovery, have a registry that we established where anyone who quit anything can give us a valid email address and answer a whole bunch of questions about their substance use, and know that we'll invite them again for subsequent study. We're in the middle of a longitudinal study using accelerated longitudinal design to study individuals in recovery from alcohol use disorder. And by using that design, we'll be able to track them over a 10-year period during a normal grant. We have like 650 individuals participating in that. We're halfway through, and our retention rate is 92%. I'm very happy. So that's what I'm covering.
Okay, our next is Kevin Lam, and he is another co-facilitator for session 3.
Hi, I'm Kelvin Lim. So delighted to be here today. I'm a professor in the Department of Psychiatry, University of Minnesota. My interest in the topic is that my research work has been focused in two areas. One in the area of neuromodulation as a treatment for substance use disorders. Another area is in the trying to identify individual causal factors related to craving and drug use in the context of EMA and causal modeling. Thank you.
Thank you. Next, Lauren.
Hello. Sorry, first I want to apologize for the sunglasses. I have a scratched cornea that's taking forever to heal. But my name is Lauren Hoffman. I'm a research psychologist and assistant professor at the Recovery Research Institute within Massachusetts General Hospital and Harvard Medical School. And my research primarily concerns opioid use disorder treatment and recovery through a biopsychosocial lens. So both looking at neuropsychology as well as psychosocial aspects that are important to treatment and recovery. And my work emphasizes translation to real world populations. And at a more personal level, I also have what I call secondhand lived experience. So I'm the oldest child and primary caretaker of a parent who has had a particularly long and difficult journey with opioid use disorder and later methamphetamine addiction. And so that's provided me with a very much appreciated perspective on addiction and recovery that I try to leverage in my work.
Thank you. Next, David.
Hi, I'm David Epstein. I'm what's called a tenure track investigator at at NIDA's intramural research program in Baltimore. I've been at NIDA for more than 25 years. I'd originally been trained in behavioral pharmacology, mostly in rats, and neuropsychology in humans, but now I call myself an addiction researcher, which means to me that without discounting the biomedical things that I was originally sort of focused on, I'm increasingly interested in levels of explanation and intervention that are psychosocial and social structural. And I do human research. It's mostly been on opioid and cocaine addiction, and that's involved a lot of work with smartphone apps for real-time assessment of people's mood and behavior in daily life. And sort of hand in hand with that, I advocate for acknowledging that human experience with drug use is profoundly broad. And I like to think that a lot of that breadth can be modeled in lab animals. And the more fully it's modeled, the more those animal models can help screen biomedical treatments for the subset of people, and I think it's only a subset, who need a biomedical approach to their recovery. That's my intro and manifesto.
Thank you. And Jerry.
Hello, everybody. Jerry Moeller here. I'm a addiction medicine and psychiatry provider at Virginia Commonwealth University. On the clinical side, I'm the division chief for addictions, but on the research side, I lead the Wright Regional Center for Clinical and Translational Science. So that's a translational research center funded by NIH. And my research focus is on translation, which people have mentioned so far, which is trying to take discoveries from the basic science side and move them out into having an impact on health in the community. So in our research focus recently has been medication development.
Great. Thank you so much, all the panelists. So now, Warren and Kevin, please take it on.
Warren, would you like to start with the first question?
Absolutely. Based on the discussion of recovery capital on day one, what social, environmental, subjective, clinical, behavioral, or neurobiological variables are necessary to model the recovery process fully? And an addition might be that practically.
And I was thinking about trying to channel John as we get started in our discussion. Really, this is a discussion, is that the purpose is not to develop consensus. Probably the more important thing is we're trying to collect ideas and spur discussion. And so there may be things we want to measure, but we don't know how to measure. But hearing the very broad set of expertise and background on the panelists and participants here, I think if you have an idea of something needs to be answered, but you don't know how to answer it yet, that's okay. Good to get it on the list. Jess, you have your hands up. Your hand up. Your official hand up.
So for clarification for some of our participants with lived experience, can you explain a little bit more about what you mean by modeling and metrics, and give a little bit more context for a non-researcher on what you would like to hear from us in sort of this first question for the whole group?
Yeah, so I think what we're interested in is what things can we measure that we think are important to the recovery process, and recognizing that as based on the lived experience discussions of last week, can be highly diverse, but we want to try to capture the things that are important to support or initiate recovery, and want to measure those. In terms of the different measures here, right, there are the different spheres that we could measure. You know, we know that the social determinants of health can sometimes be impactful, but what are the right measures of that? We certainly know that the personal experience, the experience with clinicians can impact the recovery process. And what are the processes there that we'd like to understand better in terms of behavioral or decision-making processes or neurobiological variables. We may not be able to measure a lot of those very conveniently in certain contexts, but do we have an inkling of what may be relevant to support recovery? This is consistent with what we just talked about. We're trying to collect ideas and collect notions that we may have otherwise missed or haven't developed into deeply enough.
Jess, does that help?
Yes, very helpful.
Okay, great.
Just keep-
And I see David's hands raised, and then we have Noel, and then Lauren.
Yeah, I was just going to add to the answer. When we talk about modeling and specifically animal modeling, we're basically talking about a system, a laboratory system that's set up in lab animals, typically rats, not always, that enables us to study patterns of drug use and brain bases and effects of drug use, and to screen possible interventions or treatments. And I'll be quick about this, but I would say it's evolved. I mean, for a long time there was only passive administration. The rats would be injected with amounts of heroin or cocaine or whatever other drug that the experimenter thought that the animal should get. And it was a breakthrough several decades ago when it was discovered that lab animals would self-administer certain drugs. And then you could study, okay, what happens when they choose to do this to themselves? But even that there's been an evolution from that, in that we now understand, I think, that if you give an animal a choice between doing absolutely nothing and using heroin or cocaine, you can learn only so much from that. And you really want an animal model where the animal has skin in the game and has reasons not to keep using or not to use to excess. Anyway, that's my quick thing on animal modeling.
No.
Yeah, so I think one of the limitations, so I'm going to answer this in a few different ways. I think one of the limitations that I would bring up right away with animal modeling is that it's not very good at least up until this point, it's not very good at modeling polysubstance use. And nearly everyone I know in recovery is some kind of polysubstance use. Hardly ever do you get it to follow that perfect, rodent model of like one specific drug, one specific outcome that we see a lot of the time in the preclinical work. And so it really has a lot of time, relating to human substance use. And so the example that I'll give is that, a lot of the medications that are done for one, I'll just say for opioid use disorder. So we have this medication, buprenorphine or whatever it may be for opioid use disorder, not taking into account that maybe 80% of those individuals are polysubstance use. And so while it may work for one their addictions and have really great, you know, the signal may be very strong, as we see for buprenorphine, as far as stopping overdose and preventing relapse. You know, that medication is not helping with the other substance use disorders that person has. And so I think that, you know, we've gotten into this world where it's like, you know, medications. And again, I'm not saying that they are not important. They are a huge part of the puzzle, but they're just part of the puzzle piece. And so that's one thing that I would say. As far as ideas around specific things that you can measure that would be important, I think thriving is really important. I think quality of life is a super important. These are drug use types of things that I'm thinking. I think that, you know, what I talked about earlier, as far as like and again, I'm sure there are out there people have already measured this, but what I talked about last week, where we're talking about the identity of a person, right? As that person kind of claims this identity of someone in recovery, and it's a long process, right? I mean, it's not usually like you just wake up one day and like, oh, I'm in recovery. It's usually this lifelong process to where you kind of gain this recovery identity, and you become kind of, I don't know, I'll just say proud of that identity recovery. And so if there's some way to get at that identity of recovery, I think it would be really important. And then, you know, I think another thing that's really important that's missing in this conversation is understanding what communities are recovery ready. We don't have many studies out there documenting the number of collegiate recovery programs in a state, or the number of RCCs in a state. You know, these are the things that make our communities recovery ready. And until we have a good number of these in a lot of different communities, I think that, you know, we're probably not going to get to the level of seeing, you know, people recover super well in certain communities if they're not, I'll just say, recovery ready. So and I would say like state level or community level or city level documentation of number of recovery community centers, number of OPCs, number of collegiate recovery programs, number of recovery high schools. I think those kinds of studies would be really important as well. And I will be quiet now.
Hey, Lauren.
Yeah. So I would just one question I have based on this.
Oh, Lauren had her hand up.
Okay, I'm sorry. I thought you said Warren. Good.
I said Lauren. Sorry.
Yeah, so I mean, at the risk of being a little too repetitive from last week's session, I think that we really heard what needs to be modeled, right? So number one, we have several different pathways to recovery, and we need to be modeling those. So from treatment, medication treatment, all the way to exercise. Somebody even mentioned incarceration as something that benefited them, which surprised me a little bit. In addition to that, you know, the sociodemographics that are important. We heard Corey talk about race and ethnicity and the importance there. It's also important to be looking at sex and gender. But also, one of the things that I think we didn't hear enough about was social relationships within the context of family and family dynamics, and how that plays a role in someone's recovery, and what dynamics are going to support a person or hinder their trajectory. Obviously, things like employment, education, financial stability, we heard a lot about that as well. So I don't want to be too repetitive here, but Noel also had mentioned quality of life, happiness, self-esteem, right? Like these are all things that we typically measure in our recovery research. Spirituality, religiosity, what are the patient goals and how do they align with the individual who they're receiving care from? Obviously, there are all the clinical measures like substance use disorder symptoms, withdrawal, change in co-occurring mental and physical health disorders, and then behaviorally, I think we need to be measuring use of various services and how that changes over time longitudinally. in not only early recovery, but also later in recovery. And I'm not exactly sure if there's a solid measure out there for this, but I heard a lot about giving back to the community and that being really, really integral to sustaining and supporting recovery. But something that I didn't hear a lot about, but that I do research in this area is cognitive function. And, we tend to not focus on it unless it's glaring impairment. But most individuals who are using substances for a long period of time are going to come in with some level of deficit that may not present necessarily as an impairment, but we use our cognitive ability for everything. If I'm sitting across from a counselor and I'm having difficulty in my cognitive function, I'm listening to somebody else. I have to perceive the information. I have to take it in and process it. I have to be paying attention. I have to manipulate the information to use it in my personal context, right? They're giving me all this great information to support my recovery. So I think that we've studied this a lot more in the context of alcohol. I know that at least for opioid use disorder, there are very few studies that are looking at how people recover over time longitudinally, whether on medication or not. And then I think it's something we need to be focusing on because there are ways to enhance people's cognitive ability and help make their function, help them improve their function more efficiently, right? Cognitive retraining batteries and those sorts of things. So in addition to everything that was said on day one, which I think is also very important.
Good. So Warren, and then Ashley and Jess and Tanya.
Yeah, so the one thing I just wanted to make sure we didn't made sure that we were thinking about as well is the 60 or 70% of people who consider themselves in recovery who never went through a formal treatment program. Right, that's like a big black box to many of us, right? Because they don't have any contact with any of the type of programs that we might have, and trying to understand to the extent that they follow similar pathways or completely different pathways, I think is really something that we should consider.
Ashley.
Well, actually, Kelvin, real quick,
Go ahead, John.
let's get Jess' question in case it's a clarification one.
Sure.
Sorry, Jess, not to put you on the spot while you were turned around.
Sorry.
No.
Teenager had a question. I just wanted to jump in on a couple pieces and just to reiterate a few items already raised by some of the panelists. I think it was Lauren who mentioned making sure we pay attention to biopsychosocial needs in recovery. And I think sometimes, and this is a little bit of reiterating Noel's comment, we get really focused on the biological pieces or the neurobiological pieces that medications or things that I'm doing for the withdrawal cravings, the physical needs that I have. Then we're shocked that treatment or recovery didn't work because we ignored the psychological and the social components of this. And when I was just out doing a workshop on Friday, so I was feeling very it was reminding me of our great discussion last week. When you ignore the social piece, it's like not having the first slice of bread in your sandwich. It's just going to fall apart. Like redoing the first things that when we work with people that are doing the hard work of treatment and recovery is reconstituting your social environment. You're cutting out people and places, you're rebuilding new friends. There's just so much work that goes into that. And I feel like we focus on the biological piece, and then we forget about the other two components. And whatever measures or metrics or vital signs you find in the B side, there has to be just as many, if not more, in the psychological and the social side, or this does not work. On the social piece, we are social by nature as humans, and having to redo your friends network from scratch, however old you are when you enter treatment, that is so much work. And everyone who's in recovery, who's on this Brady Bunch panel, rebuilt their social context. And that is just a beautiful, profound thing. And there needs to be metrics for that to understand. And then if you ignore the P part of it, the psychological part, so many of us, not even those that have a substance use disorder and recovery, but human Americans over rely on substances for stress management, coping with day-to-day big stressors, too much alcohol and cannabis use in general for coping mechanisms. We have a lot of maladaptive coping. And for those in recovery and treatment who have rebuilt coping mechanisms that do not involve substances, how much work it takes, right? How much work for distress tolerance, how much work for emotional regulation, how much work, not just to handle the loss of a family member, a job, or a breakup, the big stuff that we think of as stressors, but sometimes it's the little things that are stressors, the sort of like neurobiological, the sort of pathways we have in our brain, and this is how I de-stress from a day, or this is how I handle an argument, this is how I go to sleep, this is how I have sex, this is how I wake up and get my day motivated. Changing those behaviors and all of those coping mechanisms, turning them from maladaptive to healthy is so much work. And I think that there needs to be equal metrics in all three of these domains, or we're not doing a good job of measuring the work that it takes to find remission, which is just beautiful, but a lot of work that everyone's seemingly managing on their own, right? So when we talk about folks that didn't do regular treatment through a healthcare provider or through a specific specialty treatment, that might be, but what they did then was self-manage a complicated chronic condition and built a multidisciplinary, multimodal treatment plan on their own. They did psychoeducation to learn about their health condition. They rebuilt their coping mechanisms. They reconstituted their social structure. They came up with new ways on what they do when they're hungry, angry, lonely, tired, or bored. They, came up with new routines and regimens on how they handled distress and difficult emotions. So I just think that there needs to be equal numbers in the middle and the middle of the sandwich and the foundational layer across biopsychosocial. Otherwise, we're not truly capturing what it takes to get there.
And I completely agree, Jess.
Hey.
Ashley.
Yeah, and I think there's a range of these different categories, like Jess was saying, and making sure that we're thinking about each of those. But then I also think that when we're thinking about like converting it into an animal model, if that's part of the goal, it's like two columns, and maybe there's a Venn diagram, maybe they're not columns, but it's a Venn diagram and there's some overlap. But there's like what does recovery look like for the individual? And that's the different buckets of that thriving, the managing cravings, managing pain and stress of all types, as Jess is talking about, having purpose and feeling like I have something to contribute, and those relationship aspects, and feeling belongingness and the internal part of what that means of that flourishing. And so it's what recovery looks like for the individual. But then there's also, what does it take to achieve that? And I think that for the animal model, the what does it look like is the critical piece to define, and making sure that we're not blurring that too much with what does it take to achieve that. And maybe it's for some people it's the treatment and peer services or collegiate recovery program, or for like Warren said, many people it's none of those, no sort of formalized service and the capital that it takes to achieve that, and some of which could also be the signs of recovery, of an individual's recovery. But there's what does it look like for me as an individual in an animal model, and then what do I need to do to get to recovery or maintain my recovery? And that may be blurring that too much means that I think we spend time on like, these are the interventions that would be needed, or the community characteristics that would be needed to get someone there, but we might not put enough effort into what does it actually look like for the individual to be in recovery.
Anya?
Hi everyone, I'm just going to briefly introduce myself. I'm a medical officer and program officer at the Division of Therapeutics and Medical Consequences. And also I'm a program director for novel endpoints, substance use disorders. And I will be making a couple of comments based on my background as a medications developer, or should I say therapeutics developer. And from what I hear, there is a perception that we have like animal models, and then we have sort of, we talk about recovery processes, but in between lies what drug developers call a valley of death. It's when you, in clinical translational part, which is substantial, when you use medications to try to see, or therapeutics like vaccines, whatnot, when you use them and you try to discern the signal, whether they're helping the person or not. So that's where a huge problem lies, because whatever beautiful looks in animal models that David was talking about, it may as well fall flat in those studies that where we need to see whether they're helping or not. Then we talk about recovery and the recovery capital and the domains that recovery capital is shaped from. And I wanted to comment what Lauren actually brought up. And she brought up a very important point. Like the cognition piece that the recovery capital has as a part. It is not only how you retrieve the information and manipulate the information to answer, let's say, a test question, right? It has also other part, which is called social cognition. It's like what Jess was talking about. You rebuild what skills do you use to rebuild your friends' networks? What skills, what are your outlooks on life and various life questions? It's changed, but how to measure it and how to connect it with what we see in human translational research. This is a huge gap for us, and we need to expand our understanding. So there are things like in social spheres of cognition, like again, as how do you see a world around you? How do you deal with the friends? How do you deal with the work? Do you see, actually, are you flourishing? That's all that you need to cognitively understand. So there's two important points, I think, that we may want to discuss. Thank you.
Real quick, just for clarification, Kelvin or Warren, can we go through animal model versus clinical versus preclinical, like the various levels at which we can do this modeling here? Because we're not just trying to replicate it in animals, but there are, you know, different ways to study the kind of phenomenon that we're talking about.
So you're breaking down preclinical.
I think
John?
it would help. I think it would help some of our panelists to understand what you mean by the difference between these different phases, if there are terms that are new to any of the folks who are joining us.
David, you want to take a crack at preclinical versus clinical? Because you kind of bridge both.
Yeah, I was afraid someone would call on me. Preclinical is the usual shorthand in our neuroscience addiction research circles. Preclinical is the usual shorthand for laboratory animal work, and clinical is the usual shorthand for human work. Actually, and here's another mini manifesto. I bristle a little bit at the fact that I think, at least in the circles that I travel in, clinical has become a synonym for human research. We say we do clinical research when we're really doing human research, and I call myself a human researcher because I don't work just with clinical populations. I don't work just with people who need attention from clinicians. I work with humans who are using drugs for a variety of reasons. But that's my soapbox. Anyway, yes, preclinical, lab animals, clinical, humans.
Thank you.
Thanks, David. I want to return to this thing that several of you brought up, but thinking about that really intrigues me is measuring flourishing. how can we do that? Channeling John here, and how do we do that at the clinical or human as well as the preclinical piece? So. Jerry.
So I raised my hand before you asked the question, but I can try to answer the question. I mean,
But continue with your thought too. It's okay.
Well, it ties in with what you're saying too. And that's really, because we haven't talked at all about when you go down that translational pathway of trying to develop new treatments, eventually you're going to run into the FDA. And the FDA has very specific guidelines on what they think are outcomes that you can use to get a medication approved for use as a treatment. And so, and those guidelines tend to be driven, if not entirely, almost entirely by abstinence, by measures of urine drug screening. On Wednesday, there's a large discussion about how abstinence is related to recovery, but it's not the definition of recovery. And so those other outcome measures you're talking about, I mean, some of them, several of us on the screen have modeled other outcome measures, like craving was mentioned, decision-making, impulsive behaviors, and various other things that are part of the overall recovery process. One thing that I wanted to, where I was going to go with this is to ask some of the other panelists about something that was mentioned repeatedly on Wednesday, which is the voluntary nature of recovery. That, like, I think it was Michael who gave the SAMHSA definition of recovery, which was, I tried to write it down, but tell me if I'm wrong. It was any positive change that is self-determined, unique to each individual, and unimposed. So that voluntary nature of things, and which we don't model well at all. So the whatever that definition was, if somebody was saying it wasn't the SAMHSA definition, but that several people mentioned the voluntary nature of this, and that is something that we don't, at least in clinical trials, which we are doing, that's not something we're going after. In fact, we try to get people, because we're really want to get people into clinical trials, we often have people who are really not motivated at all for treatment.
Lauren.
Yeah, so just to sort of comment on your question about flourishing, I think that one way that we can get at aspects of flourishing in human research that we're already starting to do is to measure recovery capital in the various domains of recovery capital. If we're trying to really better understand flourishing in these different domains, we probably need to use those longer measures. As much as I love the brief measures of recovery capital, we probably need to better understand what's going on within those domains. I also think something that we often overlook in human research is the power of qualitative research and really better understanding how someone is improving, because flourishing can look different to different people. So if we want to take that individualized approach, starting at a place where we're getting information from individuals qualitatively, meaning one-on-one interviews, where we're asking open-ended questions and allowing for those open-ended answers, that we really might be able to better understand underlying mechanisms or things that are common across different individuals that we can then study in a more systematized way.
David?
And one place to look for this, I think, is in the work of Katie Wittgiewicz, the alcohol use disorder researcher and psychologist who she was mentioned in the last set of panels. And I'll mention her again because she's published so much good work. And she, within the past 5 years or so, has published at least one paper about instances of recovery from alcohol use disorder that can include some heavy drinking. And I would have to go back, and I can post a link to it. I'd have to go back and see exactly how she operationalized everything, how she defined everything and put it, and made it and measured it. But that would be an example of how, of how someone can put into practice a kind of assessment and classification where you say, okay, I'm saying that this person is in recovery and that they're successful. They're saying it, I'm saying it. And at the same time, sometimes they let themselves have some heavy drinking. So that's just an example of how that kind of work does exist. And I'm going to find that and post a link to it in the chat.
Ashley.
It seems like harm reduction would be like measurement in the harm reduction realm might give us some indication, right? Because it's making choices in the face of something, making choices, and it's that degree of harm reduction is maybe different for different individuals, but it's for this, you're talking about I'm making choices, but I'm still successful. I'm still being successful in my recovery. And so maybe that could help us give some examples and some indicator of how to, assuming there's successful measurement in that realm.
Channeling John, Jess, do you have a clarifying thing that you need to ask at this point? Then we'll go to Tanya.
You can come back to me. I just had a little tiny comment.
Okay, Tanya.
I just wanted to follow on that, yes, there is literature and people researched the recovery capital in alcohol use disorders. And I just sent out to everyone the most recent paper, which I find very useful, Hagman et al. They give there the definition of recovery capital, and I think they create sub-parts of it, which is maybe useful for us, I think. And please look at it, see what you're thinking. Noted.
I would also say that David Best and Bill White's work on recovery capital is also a really good place to start.
Jess.
So sometimes I think of recovery capital as like the things that we need to get there, right? And the things that are, when they're not there, can be such a major barriers. But I almost think of it in different ways of for like long-term just monitoring how folks are doing. And I think there's a lot of researchers and clinicians on this call. And I think you already have a lot of these measures. You just think of them in different ways. I love the few panelists who've mentioned two words, thriving and flourishing, right? But the thing that I think is important to note is that we don't thrive and flourish any differently from other humans just because we're in recovery from a substance use disorder. So how would you measure thriving and flourishing for a cancer patient or a schizophrenia patient or a diabetic sort of patient with diabetes? I don't think it's different. And I think that sometimes we make the mistake of thinking that, so it's not the absence of substances that we're using, whether or not someone is a mild or moderate drinker, but has cut out another substance that they had used chaotically, but the flourishing piece is still the same. And I know it's a little old school, but I still like the brief addiction monitor, at least a few questions that are in it, because I like certain questions of how are you sleeping? What are your symptoms of anxiety or depression or sadness? What are your social indicators versus isolation, right? That's a really important one. Do you have a sense of purpose? Do you have meaningful involvement in work, volunteering, or school? And then there's one, I don't know if it's in the BAM or in the ASI or something else. There's one about, tell me about your relationships. Are you having a lot of conflict in your interpersonal relationships? How are you getting along with your partner, your mom or your dad or your children. So it's social health, relationship, purpose pieces, maybe some stuff from PHQ-9, but I think a lot of the ways that you would try to assess whether a cancer or sickle cell patient was healthy, thriving, and flourishing isn't very different from how we thrive and flourish, right? And it's about the outcomes and how we're living our lives. And so I'm just sort of speaking up as an advocate for patients and families and individuals in recovery. We over-focus on the substance instead of looking at the absence of that chaotic use means that your life is returning to normalcy. You're living a self-directed life, and we're looking for positive outcomes and a variety of sort of dimensions as a human. And it's social, it's purpose, it's stress levels, it's mental health, it's having the things that we need to live and take care of ourselves and our families or children or whatever that means. So I think you probably already have all these metrics in all these other health spaces, and it's about applying them to us because we're just as worthy of them.
Jess, could you help me understand I have this intuitive sense what you mean by by chaotic use, but I think even being able to quantify or measure that is a very interesting concept. It's new to me.
Yeah, I think that, we have some individuals that we work with that are in recovery, let's say from an opioid use disorder, which they use chaotically, meaning that I did not have control over the use of that substance or that it caused consequences in my life, right? But I may not use alcohol or cannabis chaotically, right? So I think sometimes we get this all or nothing thinking, which all the psychologists on the line might love that tendency. But we even have that in our own research. When reality, it's the lack of control over the use of a certain substance, right, which is indicating to us severity and us sort of developing that problematic use. And it doesn't always mean that there's chaotic use of other substances. It may also mean that someone is intervening and starting to get help or services where it's moderation, right? So let's say someone comes out of, I use the pandemic as an example because I just way too many people drank too much during the pandemic, as we all know. But let's say you developed a mild alcohol use disorder during sort of shutdown orders and stuck at home. But if it was two symptoms, it's mild AUD, a little problematic, having some consequences, but you're able to moderate that use and cut back your use, it doesn't mean that abstinence only would be the indicator of success in recovery. It would mean that you have the ability to moderate and that this is a substance where you're not losing control. As a reminder from last week, my mom described being in recovery as being back in the driver's seat, right? So we have to, I think, listen to the patient and understand which substances make them feel like they're not in the driver's seat, and not always assume that that means that all substances make you feel like you can't be in the driver's seat. I don't know if that makes any sense or if anyone wants to jump in there, but I think we can jump into that all or nothing thinking in there when actually this needs to be, we need to look at the actual outcomes for the patient, not just what the substance use looks like itself, but how are you doing in terms of self-directed life, managing, not having any chaotic use of anything. And remember, it's not just substance use, because if you cut out substances, but you now have process addictions where you have other compulsive behaviors that you've replaced with that substance use, that's maladaptive. That's not healthy either. So it's really about helping patients to manage life without any of these components that are going to be unhealthy to our overall wellness.
Warren and then David.
So yeah, as we measure these different aspects, I think it's important to think about how we could differentiate. And I use this word probably in a slightly different meaning than we often use it. What are the enabling conditions? What are the necessary conditions to move into some form of recovery? But what are the threshold conditions? Because you can have all the enabling conditions, but if you don't have the threshold conditions, you're not going to make the transition, right? So I can have all the fixings for a cake, But if I don't mix them and apply heat, I don't have a cake, right? So they can have all the resources necessarily, right? But what are the threshold conditions that support the transition state? And if we could think about that, is it possible that we could start identifying the precipitants of the changes in threshold?
David?
I was just going to riff a little bit off the idea of chaotic use versus non-chaotic use. I think of chaotic use as use that is somehow not integrated into the other aspects of the person's life, that is interfering with, disturbing, impairing the other aspects of the person's life. And we've tried to get at this a few ways in some of our studies, but in terms of like daily live real-time reports of people who used the drug kratom and asking them whether it had right on the spot, following up after each use and asking whether it had interfered with the day or whether it had actually been helpful for what they had to get done that day. But we did a survey of what some ethnographers and sociologists have called a stake in conventional life, which is basically a feeling that you have a lot to live for and a lot to lose, and this seems to be a protective factor for people who use drugs and don't become addicted to them. If they have a sufficient stake in conventional life, they will control and moderate their use because they don't want to lose what they have. So we tried to get at this in a survey, and we were asking people about, why don't you use more drugs than you do? And we sort of contrasted that with various other reinforcers and pleasures in life. And at least one person in a fill-in response that I found very thought-provoking said, I reject the terms of your question, because for me, this person said, it's not that drug use or drinking or other drug use is in competition with the other pleasures in my life. They are integrated. They can, the slight intoxication from whatever it is I'm using can actually augment the pleasure that I'm feeling from something else rather than disrupting it or competing with it or displacing it. And the other point I want to make in relation to that is that I think about that sometimes in animal model work that we've been seeing, where, for example, rats choose between access to a little bit of alcohol and access to another rat. And those two things are supposedly placed in competition with each other. And I looked at the data, and in some of these studies, it looks to me as if rats could be doing what people are doing. They're alternating. They're taking a little bit of alcohol, and then a little bit later in the same session, they're getting access to another rat. Maybe, like people, rats can combine these two things. I just want to sort of extend the discussion of chaotic use and alternative I just want to extend that a little bit. I know that was a little discombobulated, best I could do on the spot.
Vishay?
Kishi, I think Calvin was calling on you to speak next, but I don't know if you heard him.
Or Vishay, can you hear us? Vishay?
Looks like we have a connectivity issue.
Okay.
Casey, when you're back, we can come directly to you.
Warren, you want to move to another question, or you want to continue this discussion?
I think we probably worthwhile for us to think about the additional questions we have here.
Should I move on to the next one?
Yeah.
Okay, so our next question is, what essential concepts are or are not being modeled?
And just to clarify, you mean in preclinical work?
I think it's preclinical and clinical.
Marco?
Hello, everybody. I think preclinical, what we are missing is the impact of society towards people using drugs, because especially at the preclinical model, at the preclinical level, we focus on one rodent, the rat that is taking drug, and we do everything in the brain. We check what happened at the neurobiological level, but we do not focus on what society, the role of society on that rat using drug, which based on the discussion that we had Wednesday and the discussion we're having this morning, it seems to be very, very critical to focus on the societal component of it and how people support people using or trying to abstain from drug.
Lauren and Kashe, when you were able to respond, please give us a signal.
So coming from a human clinical research perspective, I think that I'm not sure how to get around this, but you know, most of us applying for NIH funding means that our studies are likely going to be limited by the time of funding that we have. So we have 5 years max, right? Typically. And so if we're studying people longitudinally, we're really not able to get that picture of what recovery looks like over time. We heard on day one, there are lots of fluctuations. It's non-linear. There are different things that are essential or important at different periods along that trajectory of recovery. And I would say that that's something we're not modeling that is critical, but I'm not sure how to overcome that because I'm not in charge of funding or how we can do these really long-term studies that are looking at people over time and capturing all of these different recovery pathways. One of the other things that we're not doing, I think, in research as well is looking at that individual variability, because the majority of the statistics that we're using are lumping everyone together. We're looking at averages. And so we're looking at what's best among the average person, or we're taking a lot of variability and saying, well, you know, if we whittle it down, this is what we think it is. But I think that we're doing ourselves a disservice by not looking at those subtle differences between subpopulations and how that really might impact the trajectory, the recovery trajectory, and how they engage with services or other people socially, or how they recover over time.
Ashil?
Yeah, I agree with what Lauren's saying, and want to make sure that it's like for the record that we reflect back to a conversation we had last week of that recovery. If we're going to measure recovery, we need to think about also measuring it, what it looks like at different phases, and it's not always linear. And so knowing that people may fluctuate but that you know, early in recovery, the measurement of recovery may need to look very different than later, or, you know, after there are different cycles. It's sort of like I always say, you don't know what you don't know until you know it. And if you talk to someone who's, you know, in long-term recovery, they value, they you know, may place values differently than the person who's in sort of early recovery. So that's one point, is I just wanted to make sure that stayed in the thinking, and for subpopulations, like Lauren was saying, what looks like recovery in an adolescent or a young adult is going to look very different than what recovery is valued, what aspects of recovery are valued later in life. And so that's one comment I wanted to make sure stayed in the realm of thinking. The other point is more like a question, and it's just because I'm fascinated. I don't do research with rats, was never trained as a rat researcher, but I'm just fascinated. So I do recall a little bit from training that rats are social creatures. So is there any reason why what Marco and what David were talking about, you know, the decision-making and the processes that animal models use, is there any reason why we couldn't model some of those social elements in an animal model?
Tanya?
I just wanted to ask, it would be important to ask ourselves the question, because we, even for example, if you'll be doing longitudinal studies, right? Let's assume that we have that luxury. How would the beginning, the start, like Warren was saying, the threshold condition, the start of the recovery process would be like? Would it be is there any possibility to create some understanding around this? Like, because, you know, I'm in recovery. Is it voluntarily you kind of declare yourself being in recovery, or there is something else that is needed? That's one comment. The second more comment, I'm going to perhaps preempt Marco a little bit, saying that I believe that Marco, David, your group did something, animal modeling, that included the social factors sort of in competition with drug taking, but I will give the floor to Marco on that, I think.
Yeah, we can model social construct in rats. I mean, with David, we have been working the last few years to model this aspect in our rats. So pretty much we gave a choice between an injection of a given drug or interacting with a social partner. And the majority of rats, except in some situation, will prefer interacting with the drug, even if these rats will meet the criteria of addiction for rats that we can discuss, but this is another topic. We are starting to address these issues and, you know, investigate more the social construct in rats. The problem is defining social, because, you know, in human, social means something, and in rodents probably means something else. One thing that we can do, though, is to model some aspect of the nuances of social behavior in humans in our models. So we can have multiple animal models for different aspects of social interaction. This is something that we are trying to do. And as I was mentioning earlier, it's time for the preclinical model to investigate the role of society, the role of the rest of the rats, because it's not just about people going through addiction, because I mean, on Wednesday, we learn how important is social support in general, but social support is different because for somebody, social support would be positive. For others, the same social support could be very stressful and actually increase craving, increase the relapse. So this is something that we need to address at the preclinical level, but I think we are going in this direction from a preclinical researcher.
Cool.
Yeah, thanks. And I really do appreciate that. And, you know, I did a lot of work. I should say a lot of work, but I studied a lot of the preclinical stuff when I was in grad school. And, you know, I think that it's very difficult, as I'm sure people are aware. And I think it's part of the reason, right? This is almost part of a larger problem. Like if you look at the number of studies, just do a Google search on addiction and look at, like, you know, prevention, treatment, recovery pales in comparison to the research that's out there that's on treatment and preclinical or prevention work. And it's because it's very difficult to model. And even if you look at any other disease, right? If you were to look at cancer and the, you know, prevention, treatment, and recovery phase, like it just, like I say, it's just largely ignored in the addiction literature. And so again, I think it's very, very difficult. And when you have those very controlled things where you can do with these rat models, where it's like this, and this, and we have these really great outcomes that we have that follow this great kind of modeling or assay or whatever it is, you know, and I would also say that we have, I think that for addiction, we have a great model in that you can basically make an animal addicted to these substances and then look at things. And so that's really, I mean, for any other disease, depression or mental health, like we don't have those same kinds of, like, you know, being able to really model it. But it's because as you get further away from that, you know, kind of understanding the brain processes to understanding those social things, it's not as cut and dry, and you don't get the results that you get in some of that early preclinical work. And so it takes a lot of work, and it takes a lot of failure, I think, too, which, you know, I think a lot of times people that are so used to their animal models, they don't want to mess with that. They don't want to kind of look at that. And so that's one thing that I kind of wanted to bring up. I think that the other thing that I would bring up is it's very hard to examine negative consequences, and negative consequences are a huge part of recovery and substance use disorder in general. I know there are models out there where you can, use some of these foot shock things to see if an animal will run back to the substance. And I think those are definitely a step in the right direction. But negative consequences are so complex, and the criminal justice system plays such a role in recovery by the time a person reaches recovery, for most people. I'm not going to say for everyone, but those kinds of negative consequences are so much different than what you would see in a preclinical model. The last thing that I would bring up is that the criminal justice system, at least in the treatment industry, it is so intertwined in the treatment industry. And I'll just speak from my perspective, working in an intensive outpatient, both at the adolescent level and at the adult level. In that IOP, there were so many people in there that were, either referred by the criminal justice system or for driving while intoxicated. That's a totally different story, where it's a requirement of treatment and a requirement of past UAs for that person, for you to report back to the state. And so again, it's this infiltration of the criminal justice system. And I really hope that as we start thinking about recovery and what's important in like long-term recovery, we're not thinking about it in these conventional ways, at least of treatment in America, where it's you got to have this big kind of overlap or this big interconnection of the criminal justice system. I hope we move away from that as we're thinking about the recovery phase of the continuum of care in this work. And so I know it's really, really hard to do, but I think that there's some systems in place in the way that we do things that, unfortunately just kind of need to be blown up. And that's really, really difficult.
Marco, then Lauren, and perhaps at that point we should transition to the next question.
I totally agree. It's difficult, and still we are far away. I think that the preclinical addiction research had a period of, everybody was following the same dogmatic thing. So we had the 3 models, everybody was working on the 3 models, but unfortunately it was not enough, because it's not easy to tell people, okay, your model is not working, we need to do something else. And also at some point in the addiction research, we lost the focus of behavior. We were getting into the brain so deeply that we were not looking at behavioral measure or how these rats are behavioral. What is the behavioral mechanism of all these outcomes? So I think this workshop is something that addiction research needs more than anybody else, because sometimes we think about our rats forgetting about people going through these experiences. So having this interaction, on Wednesday, I was taking notes like crazy, because just hearing everybody going through their own experience, it was giving me a lot of ideas to do with my rats and how we can model this behavioral outcome. So I think we need to do more of these workshops so we can address more of these gaps.
My turn.
Yes.
All right. I just want to, I did hear a little bit of a tone around sort of animal models not necessarily being the best models for studying recovery. And me not being an animal researcher, I would say that I kind of want to push back on that a little bit, because I think both are important, right? We need animal models. We also need clinical research. And I think that animal models can really help us better isolate and identify the core mechanisms of what's going on here. And then when we take them to the human world, right, we're just trying to see, first of all, can we replicate that in a simple fashion? But then can we model this core construct within the context of a complex process of recovery? So then we're taking into consideration social aspects, community aspects, things that we can't necessarily model perfectly in animal research. But I think building off of these studies in a way that really helps us better understand what the important concepts are, isolating them and then understanding them in the context of all of these other factors that we know are essential can really benefit us in having a well-rounded understanding of recovery.
Yeah, and I didn't mean to, Lauren, I didn't mean to say that.
It wasn't you.
Oh, okay. Yeah, no, I think that there just needs to be more of a balance, right? I mean, I think we focused for a long time on some of that preclinical work. I think that, you know, we need to see the level of funding kind of in this recovery area, kind of equate that to that as what we've seen in the preclinical. And, you know, in no way did I mean to say that it's not important. I think it's absolutely vital. It's shown us, it's mapped the brain pathways, which is I mean, I think it's done incredible work in the last, you know, 30, 40 years.
Yeah, and I think we probably need more collaboration between individuals who are doing these animal model research and people who are doing clinical research. And if we can build off of them together, I think it would be really useful.
So I suggest we move to the next question, which is, how well do clinical and research answers to what is recovery overlap?
Maybe you could delve a little bit more into that question as far as what that exactly means, or the underlying thoughts under that, because I'm having a hard time even kind of contemplating what that means.
Sure. So, for example, the National Institute on Alcoholism and Alcohol Abuse has developed a definition of recovery for research. I'm trying to remember the three domains, but I believe they include achieving remission according to DSM, which is a decrease in the 10 of the 11 symptoms. It's okay to still crave. Reductions in amount of use and engagement in social quality of life, I think, type arrangements is my remembrance. If I misremembered that, someone please jump in. So that's like one perspective, trying to operationalize recovery that NIAAA has promulgated and has published a more detailed view of it in the American Journal of Psychiatry. So how does that fit with the discussions, for example, of what was recovery that occurred last week? And Lauren, your hand is still up. Did you want to jump in on that?
Sure. I mean, part of me sort of wants to leverage what Noel said previously. So, and I think it was like, how do you define recovery? And on day one, he was saying, well, as a clinician, it's striving towards decreased use, sobriety, and improvement in substance use disorder related symptoms. And then as a researcher, he viewed it more as a lifelong disease with stages of addiction, right? So binge intoxication, preoccupation, anticipation, and withdrawal and negative affect. And I think that coming at it from two different perspectives and just hearing that tells us that they're not completely overlapping. I think that in research, we tend to think a little more longitudinally. In the clinical realm, we tend to define recovery based on treatment outcomes, from what I see. And in research, even though we're focusing a little bit more longitudinally, obviously there's still a lot more to study. I had mentioned previously that we're, really going out only so far following people over time, but I don't think they completely overlap. I think in both fields, we have too much emphasis on substance use, but that in the research field, we're growing a little more in the concepts that we need to be measuring, like quality of life, recovery capital, social well-being, resources, and recovery support services, and so forth. I don't think that we're doing as much of that just yet in the clinical realm, but I'm hopeful that we'll get there.
No.
Yeah.
Can I Can I jump in
Yeah.
and ask just a clarifying question real quick? Sorry,
Go
Noel.
ahead, John.
Yeah, Lauren, to that point, because this has come up a couple different times, do you think, especially from the sort of human research side, because we spent a lot of time talking about the animal research side, do you think we like, are those measures ready to be used right now and we're just not using them, or do we need to get a better handle on? I mean, like, because we sort of are talking about quality of life and being like, oh yeah, I know what a quality of life is, but then again, like operationalizing all this, like, are there operationalized versions of this that we're underutilizing, or is the operationalization the gap?
In
And
research,
that's not just for you. Sorry, I didn't want to put you on the spot, but
I think that some of the measures, there are some measures that we have that we know work, right? Like quality of life is something we have several measures for. We know that I think the quality of life measures that I've seen are pretty useful. Recovery capital, we also have several measures of that are really beneficial. I find it, personally in my work, one of the issues that I've had to overcome is trying to find measures that fit opioid use disorder. Because a lot of these measures, as they were developed in the context of alcohol use disorder. And I find myself going through these measures and the questions that are asked and being like, this really doesn't apply to individuals with opioid use disorder as much. I think that trying to find ways to make these measures relevant across different types of substance use disorders will benefit all of us as a field. However, we also need more specific measures that allow us to get some more detailed information around the person's primary drug of choice and their recovery from that substance. I think some of these measures are there. Some of them aren't, right? And I think they're continuing to grow, but I would say I think we can do better and continue to strive to do better, but we do have a foundation of good measures. I think that we do a little bit more work on validating them, all of them, and making sure they're reliable and have some predictive validity long-term.
Noel, you had your hand up a moment ago. Did you want to and then we go to Tanya?
I would go the other direction of Lauren. And I do think it is important to, obviously you want to have as many substances as possible, but I also think just polysubstance use in general too, because most people are, most people that I've met, and again, I know that, this is an N of one, but most of the people that I meet in the rooms of recovery, mutual help meetings, it's polysubstance use. You hardly ever run into people in those rooms that are just like, once in a while you might run into alcohol use only, but for the most part, people are, in my experience, very much so. I think this is where it gets really difficult, right? Because you can't ask a rodent, like, define your own recovery, right? I mean, it's impossible. Like, we just can't do that, right? And so we can't ask them to give us an idea of what they want to work on. And so, these are where it really does get hard for animal models to I don't know, keep up with this. The other thing that I would say is that, I know, and I hope there are people that do that animal research on here that can talk about, because I know that there are certain symptoms that the rodent models are really, really good at addressing. I know other ones they're not as good as addressing, but those are the things that in the clinical world, those are the you look for that reduction in symptomology. However many of those 11 symptoms that a person may have, and you look for a reduction of those. So I think that might be a place to kind of start. I don't know. I mean, if I'm going into a recovery community center, I'm not like listing off, well, I deal with this symptom and this symptom and this symptom. It's like, this is just what I got going on in my life, and it's going to be in a whole bunch of different areas. But I don't just check off my symptomology of alcohol use disorder one by one with someone that I'm working with in the recovery community center. And so that's where I think it's just difficult. I'm not saying that it's not possible. I'm just saying that it gets a little bit difficult too. The last thing that I want to bring up, and I hate to pick on the treatment industry, and I hate to pick on the some of the rodent models that we have, is that this is the other thing with treatment in this country. I think if you were to, well, I don't know if this to be true, but the way that we do it with one one drug, one intervention, one treatment outcome in the preclinical work. And then the problem is that for anyone in this country that does IOP, which is the most popular level of care, it's not like that. The intervention is not like just one. It's like you're getting thrown into a room with 12 other people that might have your same drug addiction. They may not. They may, one person may struggle with alcohol use disorder, and then 3 people with opioid use disorder, but you're all thrown into this group. And so it just, again, doesn't follow that perfect model of one drug, one intervention, one outcome. That's just not the way we do treatment in this country. And so it doesn't really match up to the treatment, and then that doesn't really match up to the overall recovery side of things as well. And so with that, I'll be quiet again.
Tanya, and then Warren.
I just want to mention what's most intriguing in the paper that I have sent around. I believe it's the same paper that Warren Bickel mentioned, because it's from American Journal of Psychiatry, Heckman et al. It mentions that recovery process is like electron. It's both a process, longitudinal process, and at the same time, it is an outcome. I think it's very intriguing, and we may want to look at this duality that actually exists and actually perhaps is okay because it kind of mimics what's out there in the physical world around us. That I found very interesting. And the other comment that I have is to follow on what Noel was saying about all those recovery processes and how different they are for each person. I think what's interesting is that there is a level of personalization of recovery as an outcome. And what's important for one person may be less important for another person. And that's how we kind of could look at the personalized approach to recovery. That's another interesting aspect of this. Thank you.
Can I just add one thing before you go, Warren? I would also add what I brought up to Lauren. So Lauren brought the things that I had brought up last week when we talked. But the one thing that I would also add is that it's an identity. For people in recovery, it is an identity. It's not an outcome. It is their identity as who they are. And that's on a spectrum, I think, but it is your identity. And so I think that is another thing that we really need to try and take into account as we think about this. And that's, again, something that's very hard to do from an animal model. And I apologize for busting it.
Yeah, I just wanted to mention, I think the field really needs to come to grips with the whole notion of polysubstance use. In my registry of people in recovery, the last time I looked, about 4,000 or 5,000 of them, about 15% were monodependent. Right? So like, how do we handle polysubstance use? We know often it takes several efforts to achieve a long-standing recovery. Does it matter what the sequence of drugs you're trying to quit goes, right? You don't have to just keep on trying to quit one over and over again to get the long-term. You might go across multiple substances through your experience. Is that an acquired, learned skill that you can learn and port from one to the other, or are each one different? I think we don't know a lot about polysubstance dependence, but it is really the most frequently occurring event, I think, out there. And until we come to grips with it, I think we're dealing with a big black hole.
Ashley.
I was going to, speaking to Warren's point is, I put this in the chat, but when you look at emerging adults, that Noel said like it says N of 1, but the data backs you up on that, and what Warren was saying too, the nearly 100% of the emerging adults who have opioid use have polysubstance use. So it's I don't know the more mature adult numbers, but I know it's true for emerging adults. Related to like it's your identity, or it's you know, there's like the social piece is, so it's I mean, can it be broken down to like what competes effectively with the chaotic substance use? And is it, you know, my drive to live out my value of my identity as being in recovery, or maybe it's the, you know, the social setting, or it's so important for me to be able to have that belongingness with my social network again. And but all of it is competing with the drive to have the chaotic substance use. And is there some modeling of that, or some I mean, we got Warren with the delay discounting, you know, data, so it's in that realm, but is there some way of capturing that identity competes effectively with, or the spirituality, you know, whatever it is that leads you to recovery and what your journey is, but is there a common thread there that it's something that takes over so well and competes? It takes over in a good way so well and competes with the decision making around substance use.
Warren?
I'm sorry. I meant to take my hand out.
Oh, okay. Lauren?
Just to follow up, I know there were comments on polysubstance use. So I think in the context of me talking about needing measures that are substance specific comes more from a research perspective, right? We're asked to put in grants that are specific to certain substances, or is defined as I'm going to study a population that engages in polysubstance use. But I think for the most part, all of us are actually really studying individuals who are engaging in or seeking recovery from polysubstance use disorder. And it's the very small minority of individuals who are really not engaging in multiple substances. Mm-hmm. And so really it's, I think if we're being asked to get at the processes of a particular substance, then for my research, I would need measures that are geared towards asking questions about the experience of opioid use disorder and recovery. But really, I think everyone is right that we need to be looking at the broader context. It's not just even if we just focus on the clinical symptom of withdrawal, if I ask you how your withdrawal from your opioids is, and you're also using other substances that you are withdrawing from, being able to distinguish those two things is going to be very difficult. And really, we're just looking at withdrawal more generally. So I agree. I think we need to be looking at polysubstance use and calling it what it is. The majority of us are already studying it.
Flo?
Hi, I'm sorry I wasn't here for the first one. I was supposed to be in both of those, in the recovery piece, and then today. So I currently work with the University of Wisconsin-Madison on the Healthy Brain and Child Development Study, and it has to do with you know, doing the labs that need to be done, but also I talked to NIDA about creating a peer support model, a study navigation peer support model for the women that Dr. Volkoff wanted to study, which was oversampling for women who have used opioids during pregnancy. And I've also been in recovery for over 30 years. And I've worked as a clinician, I've taught at the UW. I've done numbers of different kinds of things, training people who are professionals already out in the community to learn about all of the aspects of addiction. And I just wanted to piggyback on what Alicia had mentioned and Noel had started about identity. And I think, you know, one of the things that I keep thinking about while everybody has been talking, and then when you brought it, sort of crystallized it, Alicia, it made me think that the competing identities, what I have seen over the years working with so many different kinds of groups, and also being in 12-step program for a very long time, is that it's a feeling of safety, because it is still such a stigmatized condition. And I do training also, and was one of the creators of Faces and Voices of Recovery. And so we do lots of virtual training and in-person training around the country, and hear over and over and over again that there is still so much stigma. And you feel like you're in a safe place, and you start to make friends in that safe place, that safe environment that brings you back. You feel also completely non-judged. And because everybody has some sort of lived experience that they can relate to, even if they're on poly drug use, if they're just on alcohol, if they're whatever it is, it's the same kind of deterioration of what's going on in your life, but also what you're going through internally. And so that then becomes definitely something that is a competing identity for the positive. And I'm sure that's probably found in the faith-based community too, in some ways, although I've heard, it works for some people, it doesn't work because they still feel judged. That comes up over and over and over and over again. And, of all of the 12-step groups that meetings I've been to over the years, if I've heard it once, I've probably heard it 1,000 times, is that a person who leaves and thinks I've got it together, I don't really need to come to these groups anymore, I've got a great life now, will end up either relapsing or coming back from a relapse, or almost feeling like their whole life internally now and mentally has started to sort of deteriorate again in terms of their thinking patterns, and feel like they have to come back to where they feel safe in that community to keep that feeling of belonging and safety and non-judgment alive. Because when you leave those safe spaces of 12-step groups, you don't get that from the general community. So I just wanted to throw that in there.
Jabez, you want to transition?
Yes, I think, well, unfortunately, the time is up, but we still have 1 hour discussion after session 4. So here I just really appreciate and want to thank you everyone, our panelists and also our extended panel group here, for your interesting questions and also discussions. Although we may not have a solution for every question, but I think this discussion is really set up a new directions for the future research and the future collaboration. Thank you so much. John, should we take a break now?
Sure. So what we'll do is we'll take a 15-minute break, come back at 2 and start the next session on measuring and modeling. But the sort of porous border between the two, I mean, clearly everybody had a lot to say in this one, which is fantastic. This is exactly the kind of discussion that we wanted from the meeting. So we'll let Kelvin and Warren get off the podium and and participate more in the discussion, and Anna and Brenda will step in. But continuation of this kind of stuff under Anna and Brenda's guidance when we come back at 2. But thank you, everyone. This is really great. So see you in 15. So
Anna, did you get to do a mic check?
Yes.
Okay. Okay.
And
Can you hear me okay?
Yep. I just couldn't remember if in the beginning.
And we'll just give everybody a minute to file in. But when you come in, if you wouldn't mind just turning your camera on so we know that you're here. You don't have to keep it on. It's up to you. But just so we can make sure we're not talking to people's empty offices. Okay, my rule was when I got to 4 rows of screens and we could get started. So we're there. So I will hand off to Jenny to introduce this fourth session.
Much, John. Can everyone hear me okay? Great. So hi, everyone. My name is Jenny Prabhakar, and I'm a program officer in NIDA's Division of Neuroscience and Behavior. I want to start off by expressing my sincere gratitude to all panelists who have given us their time and knowledge over the last 2 days, or over the 2 days we've been together. It's been extremely enriching and energizing, and I think these conversations have really grounded us for this final session on measurement and modeling recovery. It's clear from our discussion so far that factors that impact recovery are complex, span across different timescales, subjective, and dependent on individual experience, have deep roots in social determinants and personal connections before even touching biology. So our hope in the next session is to discuss how to measure these complex factors so we have valid real-world data and how to model these relationships across levels so it has real-world explanatory value. So it's a big topic ahead and a great panel to discuss all of this and more. So Dr. Brenda Curtis and Dr. Anna Konova have agreed to facilitate the session. So I'm going to stop talking and allow them to introduce themselves and then have the panelists introduce themselves as well. And before I do that, just want to thank Brenda, Anna, and all our panelists for joining us today. And I look forward to the discussion. Brenda and Anna, go for it. It's all you.
Hello, I'll start. We didn't decide which one was going to introduce ourselves first, but I can jump in. My name is Brenda Curtis, and I am a researcher here at NIDA in the intramural research side, similar to David. We're actually in the same branch. My lab is called the Technology and Translational Research Center, or unit, not a center, a unit. And what I do is I try to combine traditional tools that we use for kind of measuring substance use and recovery and combine those with more digital markers, things that we do on our smartphone, we do online, location, things like that. And the whole goal is to develop markers for recovery, as well as markers at the fine grain level of the environment, social support, and things like that. The goal is to eventually work with collaborators and people like David in developing personalized smartphone interventions. But I really also focus on stigma and social determinants of health and how that impact people who use drugs and people who are in recovery. And I do a lot of machine learning and all of those big data things, but also one of the things, like just briefly to talk about, I believe that a lot of the machine learning that we're doing is basically qualitative analysis, just using machines to help us code. So I do a lot of qualitative analysis. Thank you.
Hi, thank you so much for putting together this meeting. I'm really excited to be here. My name is Anna Konova, and I'm an assistant professor of psychiatry at Rutgers University. And my work focuses on the cognitive neuroscience of addiction. Our biggest kind of efforts are to try to combine behavior, subjective experience, neuroimaging measures of underlying biology using computation as a bridge. So we leverage a lot of theory-driven computational models of behavior, also some data-driven models as well. And over the past several years, we've really emphasized trying to capture within-person transitions that might happen in treatment or outside of treatment at these multiple levels, again, using this computation as a bridge. And our primary goal is, I would say, mechanistic, to try to understand addiction as a dynamic disorder. But of course, our ultimate goal is to try to bring that back into the treatment setting and either determining when interventions are best to, might be most effective, or what interventions to deliver. So thank you again. And I think what we're going to do is jump to our panelists to ask them to briefly introduce themselves. So let me just open this. We have quite a few, and I think one of them is not able to join today, Sid Chopra, right? He's not on.
That's correct. He's unable.
First one. So let's start with John Curtin.
Hi, my name is John Curtin. I'm a clinical psychologist on the faculty in the psychology department at the University of Wisconsin-Madison. And my work similar, a lot of overlap with what Brenda was describing. I do work in sensing frequent daily, if not more continuous measurement of individuals' day-to-day lives longitudinally. And we use these measures to try to develop algorithms to predict both when someone needs support for their recovery and ideally what source of support should be best for them. And we're really trying to push on the when a lot to try to get temporal precision, what they need this week, this day, and even in the next hour. And a lot of this work is anchored in the context of digital therapeutic smartphone apps that help people independently manage their recovery with some autonomy.
Great, thank you. Jonathan? Downer?
So he was on earlier, but he is actually traveling in Europe. So maybe we give him a little. He may have fallen asleep.
That's okay. We have a big list. So
yeah, maybe we should just, the people which are here, do you guys want to jump in and introduce yourselves?
Susan is next to my list if you're struggling to.
Yep.
No, I'm here. Hi, everyone. My name is Susan Ferguson. I'm a professor in the psychiatry department at the University of Washington. I also direct the Addictions, Drug, and Alcohol Institute there. And in terms of my background, I'm a behavioral neuroscientist by training. I've been doing using animal models to study substance use and addiction for almost 30 years. And I would just put in one plug that in the last couple of years, we actually have been developing models to study polysubstance use of stimulants and opioids. So happy to talk about the complexities of doing that in animals and how we can use that to translate. And yeah, I'm excited to be here. And I would say, I think so far the sessions that I've seen have really given me a lot of thought. I think that as behavioral neuroscientists, as animal modelers, we spend a lot of time looking at how different kinds of drugs can change the brain. And then we're often looking at, pharmacological treatments and how those, continue to change the brain and use behavior sort of outcomes. But I think absolutely, because those are the things that we can most easily operationalize in animals. So I'm looking forward to thinking more deeply about how we can operationalize some of these other concepts that have been coming up.
Great. Marinia?
Oh yeah, no, you've got it the first time. So hi everybody, I'm Marinia Kolak. I direct the Healthy Regions and Policies Lab at the Department of Geography and GI Science at the University of Illinois at Urbana-Champaign. I'm a health geographer and spatial epidemiologist, and I study how the social and physical environment impacts access to treatment and specifically evidence-based treatment. But then also how to measure that. So how to measure things like transportation and stigma at neighborhood and regional levels, thinking of all the different barriers that are in place, and even factors of structural racism, because we found that actually does definitely influence access to evidence-based treatments. As well as how can local opportunities and regional economics influence risk to begin with. So spent a lot of time thinking about what is a supportive environment and how does that change in different places. So great to be here with you all.
Thank you. Mohammed?
Yes, hi everyone. My name is Mohammed Parvaz. I'm an associate professor in the departments of psychiatry, neuroscience, artificial intelligence, and human health at the Icahn School of Medicine in New York. Although I'm associated with psychiatry, neuroscience, and the AI, my background is actually in biomedical engineering. And I'm a cognitive neuroscientist by training, and just like Anna, study how brain mechanisms and changes occur during really two different aspects of substance use disorder spectrum. One is the onset of problematic substance use in kids, adolescents, and young adults. And on the other side, during recovery and pharmacological and/or behavioral treatments. To study these, we use brain imaging techniques, mostly those that have easier translational potential to clinical settings, as well as beyond looking at brain function, we also study the role of social and environmental factors. I was very happy that discussion was going towards social determinants of health and social aspects. I'm happy to be here and talk to you more about what we do.
Great, thank you. And lastly, Marco, who introduced himself earlier, but maybe you could give us a quick reminder.
Yes. Hello, everybody. I am Marco. I am an assistant professor in the Department of Neurobiology at the University of Maryland School of Medicine. I am a behavioral neuroscientist as well, like Susan said, and I try to develop animal models of different aspects of addiction, specifically choice between drug rewards and natural reward, with a particular focus on social factors. And then we try to model craving and relapse in our rodents.
Great, thank you. So I think Brenda and I decided I'll ask the first question just to
Sorry,
get
just
us
to,
going.
I apologize. I just want to make sure we introduce Yeshwan C as well, who's also part of this panel.
Oh, I'm sorry.
No worries.
Yeah, it's okay. The last.
Right.
So my name is Yajun C. I'm a research associate professor in the Institute for Social Research at the University of Michigan. I'm a statistician by training. I care a lot about data quality in terms of study design and analysis strategies. So my involvement with substance use disorder mainly comes from my work with the ABCD, the Adolescent Brain Cognitive Development Study, and the HBCD, as Flo mentioned. So I'm in the design and biostyle working groups to think about how to recruit individuals that can help us generalize the results to the target population, while we are able to categorize the individual trajectories of child development over time. I have learned a lot about the discussions last Wednesday and today. There are two terms keep bumping or fighting in my mind: precision recovery. We have to respect each individual's trajectory, the heterogeneity. But at the same time, how can we generalize the results to the intervention or population level so that we can carry out some overall effective strategies? So I'm trying to think how we can adopt the discussions here to the current HBCD or ABCD design, since those are still going on, and how we can utilize existing data sources like survey, administrative records, clinical evidence from the medical records. How can we link them together? So I'm a statistician by training, but I'm really motivated to solve these important problems. Thank you.
Thank you so much. I'm just going to kick off with the first question. So I think the background of this session is that when we're thinking about the measurement of recovery, which we've heard through the previous sessions, is very idiosyncratic, we have to ask two things: not only what should we target, but how should we do it? So we hope to address this latter question in more depth in this session. So maybe the first thing that the panel can comment on is, if we think about recovery as a continuous variable versus a discrete state, are we adequately modeling it in our mechanistic studies? And by extension, what are the best methods to model the time-varying nature of recovery? I guess
I'll start off.
Oh, yeah.
With that. Yeah. So, I mean, we can talk more about different strategies of how to model this, but I think what it boils down to, for example, would be the time of assessment, like how long these assessments can go on for, and the frequency of assessments as well. So in order to trust the trajectory of a phenomenon, it will be of how long can we assess it for and how fast or slowly we have the assessments for. So traditionally in the literature, we don't have longer assessments of recovery, right? We see 6 months, 8 months to a year maximum time points. And some of the discussions that we heard last Wednesday and this morning is that that recovery is a long process, and for some it could be short. I mean, it's a very individualized kind of process. So I think that we need to think about how long do we measure things for and how fast in order for us to look at the relationship with time.
Would you say that there's a good rule of thumb that currently exists in the field?
No, I don't have that information yet. But I think that we need to do more, longer and faster for us to come up with a rule of thumb.
Marinia, and then Susan.
Yeah, so I would say that we're not doing, or I guess collectively, not doing the best job with this specific topic. And there's so much more to delve into. And from kind of the community and neighborhood perspective as well, there's different support structures that are needed at different stages of recovery. And it's very, at least in the published literature, it's very early in those stages of starting to tease that out. And part of this, as well as the issue of missing data, where at what stage, like in early stages of recovery, folks are not, reaching out, right? So you don't have who, you're missing a huge number of people in the data sets that are normally used to kind of evaluate this. My colleague, Paul Jodry, and his team have developed a really interesting conceptual model trying to really piece out, like from a patient-centered perspective, like what are the different stages of recovery? And from there, where can we actually start to understand what those barriers might be, right? Where in like once you've like, let's say that you're a patient and you're focused on accessing methadone treatment, and you've been lucky and fortunate enough to find a resource that you would be able to access. If there's not great public transportation in your area and you don't have access to transit to be able to access that on a daily or weekly basis, that's a huge, massive barrier that's not going to make it accessible, right? Whereas at other stages, there may be such great stigma in an area where it might be scary to receive access because, or to even seek treatment because you've heard such horror stories from colleagues and peers and that sort of thing. So I think that we still have a long way to go.
Susan?
Yeah,
And then
so
Marco,
I was thinking of, in the context of animal models, and I think that's often a big criticism of the models is that, in people, you're talking about people that, live in their 60s, 70s, 80s, and so on, and we tend to do 6-month, time points, 1 year time point in a rat, although, the perspective is a rat lives 2 to 3 years. So we are actually, encompassing the majority of the lifespan of a rat. Is just everything's really truncated. So the time that we sort of model the addiction processes might be, whatever it is, 2 to 3 weeks to more recently, 10 weeks, 12 weeks of substance use. And then, our recovery is much more truncated. And I think we're often looking at, we sort of think of this early phase where, after the animals are off the substances, what's the behavior looking like? What's the brain looking like? And then what we sort of think of as a protracted withdrawal period. So, in 3 months, does the brain or behavior look differently than it did immediately after stopping substance use, and then more of the long term? But yes, things like Mariana was talking about, access to care, things like that. I mean, we don't have an ability, or at least in a way I can think of, to be able to model those kinds of barriers in our animals. I remember even talking to someone, we were trying to think about ways to model contingency management and different kinds of things in our animals. And they were saying, well, often, in
human recovery, you might ask somebody to take all the alcohol out of their house, right? Or like there's different kinds of ways that would happen in different kinds of clinical settings than in our animals. Again, we're often forcing the treatments on them, we're setting the conditions and stuff. So I always think that's kind of important to think about what is recovery and treatment looking like in people and how many of those factors can we bring into our animals.
Marco and then Brenda.
Susan stole my point, so I was going to say similar thing. The only thing I would like to add is there is also a semantic issue, because speaking about recovery in a rat is very difficult, because we can achieve abstinence. We can ask a rat to voluntarily abstain from a drug because of positive reinforcement or so on, but recovery per se, it's as we were mentioning, there are other barriers to consider in humans that we will never be able to model in rodents. I mean, we can increase negative consequences. We can make a conflict model of abstinence to our rats, but from a semantic perspective, speaking about recovering rats becomes very difficult.
Brenda, did you want to expand on that point? I had a follow-up question.
Go ahead with your follow-up. It probably is the same question. Go ahead with your follow-up.
Well, I guess I was going to ask if one way to anchor across species, or even a better match between the lab and the clinic, would be to decide on whether there are critical points that we want to capture and work backwards from that. So either inflection points or critical points as defined by actionable periods in the recovery process, where maybe we can either, bolster them by interventions, or maybe that we would consider it's too late to do something about, anchoring it to some critical period. Is that something that you think is reflected in the work being done? And if not, how can we do it?
Marco, you put your hand. Mine is an old hand, so go ahead.
I thought you wanted to say something.
No, I have a different question.
I think that the critical period is during this absence and this increasing craving that we can measure from rats to human. Because when you want to intervene is when the relapse episodes are happening. I mean, ideally you want to intervene before that. So with the new technology, probably we can get to the specific window when the relapse episode is arriving. And I think we could do this in animal models or human laboratory or even in the clinic, but there is still a lot more to do, because still people tend to relapse no matter what we do in our animal model. So we need to capture the phase, or how we can prevent the phase while it's ongoing, not when it's too late, as you mentioned.
So, oh, no, go ahead. I'll stop. Lauren, go ahead.
I'm not part of this panel necessarily. Am I still allowed to
No,
comment?
yes, we want, no, go ahead. Yeah.
You had mentioned your original question was about continuous variables as opposed to discrete variables, and whether continuous variables might be a disservice to ultimate goals of what we're trying to figure out. And I think that I try to take the perspective of thinking big picture. So the individual who is trying to get better, who's trying to seek recovery, the circumstances they might find themselves in which our research is going to translate and get to them. And my mind obviously immediately goes to, the treatment setting or primary care providers. And I think that it would be a disservice to them to define our outcome variables discretely, because then we're saying it's almost defining recovery without defining recovery, saying you're not recovered until you achieve this goal, X, Y, Z, and you're at this level. When I think that we heard a lot on day one, and today it's about the progress. It's about changes in that use over time, or changes in their well-being over time, as opposed to that discrete outcome that we want to define as recovered, when really we're talking about recovery as a lifelong journey and process. So just wanted to note that.
Brenda, did you want to?
I was kind of going to ask a little bit of a follow-up, but also pose out there, because I know a lot of people on the panel are working with, they have communities, they have cohorts. And when we think about tracking, because when we talk about a continuous variable, we're talking about people in studies for a long period of time and tracking them. Are we seeing any what are the barriers that we see with doing that type of work? I mean, I track people all the time for long periods of time, but one of the things I hear with reviewers, because as you track people, people drop out of your research, that you have too many people you lost. You also have periods of time that you're not collecting data, non-response, and what is a non-response versus just not responding. So I'd love to put that out there and get some comments about, when we're talking about continuous, the kind of the long term of that and what it means. And also from people with lived experience, this idea of like, what does continuous mean to them and what is too long? Warren. I mean, you have an online sample, so I'll put that to you.
Yes. As I mentioned earlier, so I have an online sample of a lot of members of the International Quitting and Recovery Registry. We interact with them in one of two ways. One is we have put up a monthly assessment and we ask people to do it. They make a couple of dollars if they do it. We can get like 400 or 500 people per month to do it, which gives us some interesting cross-sectional data, but that's cross-sectional because it's not the same people every month. We started a trial, longitudinal trial. We used an accelerated longitudinal design. So we recruit people, a cohort of people in the first year, second year, third year, all the way to the 8th year. We follow them for 3 years with quarterly assessments. So the people in year 1, in year 2 are in the second year cohort, and then in year 3 in the third year cohort. So by overlapping these layers of individuals with this design structure, we can measure a longitudinal design of getting up to a little over 10 years in a 5-year grant period. So retaining people. Well, this is the interesting challenge with grant review. I think you get what you pay for. So we compensate heavily for participation. Of course, reviewers say you're sending so much money to these people that's not fathomable. We don't like it. Well, they make them like over a 3-year participation of quarterly participation. They're going to make like $1,200. I don't think it's that much, but so far we're retaining about 92% of the sample, and we're at the halfway point of the trial. So I'm very excited about those results. What we do is we have a whole team of people. If people don't show up, we call them, we text them, we hunt them down. And so far, so good. We're going to start having some of the initial results ready to share with individuals in the near term. But it's a interesting challenge. I was very nervous about retention, and I'm so glad it's working out thus far.
Thank you.
Marinia?
Yeah, so I guess my comment kind of extends to both some of the questions that were previously posed and noted, but I think that in some ways I want to push back a bit further or in a different direction, where like to me in the research that I do with my colleagues, like we don't like it versus kind of just focusing on a very specific impact of a drug on biochemistry and just that specific impact of heroin or whatever drug of choice you want to look at, to like from a broader perspective, like there's a much bigger social political landscape that is kind of penalizing people for a specific medical condition that they have. And it seems like that is influencing the results much more, or I mean, even, you know, comparing policies that we have here versus other countries. And that seems to make a pretty big impact. So I think if there's a kind of treatment outcome, I would look at the policy landscape as part of that. Like we definitely see that influence the work tremendously. Like in Illinois, our team did an analysis doing a structural risk environment review of at a zip code level of many different areas in a generally very rural landscape, and found very different kind of micro communities and environments. And qualitatively, a different part of the team also interviewed individuals throughout the study area. Just to kind of give an example, you know, there's one area where there's a good amount of resources nearby for different types of evidence-based medications, and a reasonable amount of you know, economic opportunities as well, a little bit closer to the main city and that sort of thing, but very little folks accessing treatment because there's such great stigma, like super high stigma. People had been treated very poorly, not just at if they did seek out treatment at a medical-based place, but also at doctors' offices. So there was a huge distrust of the medical environment. In a different part of the rural, the same kind of, you know, couple dozen miles away, a different area that had very few economic opportunities, very few resources, also was one of the only non-white areas in the entire region, also had disproportionately higher rates of drug arrests, despite there not being like some of the fewest drug use in the area. Well, at the individual level, when people were interviewed, a lot of people had access treatment or had expressed a desire to access treatment, but were not actually able to get into anywhere. So here you have these very strong social political landscapes influencing individuals in very different ways. And it, I mean, regardless of how the drugs are working or not working from either, you know, or from either side of it, like without addressing those really key structural barriers, I just don't see a way forward.
Okay. Noel? No?
Yeah. Sorry. Yeah, I'm chiming in here too. I know I'm not part of this panel, but I did want to.
Everybody is welcome to chime in, please.
Okay. Yeah, no, it's and this is absolutely wonderful. So one thing that I remember a few years ago, I was a very new researcher and I showed up to CPDD and I made a suggestion in one of the events that I was in, presentation that I was in, was just around like this important, I think, in the trajectory of a person in recovery is this idea of a rock bottom experience, right? And I was very, very, I don't know, it was just a very not helpful experience for me. I basically got yelled at by the person doing the presentation that there was no, evidence that a rock bottom moment has to exist for a person to kind of enter into recovery or to kind of get better. And I think that, the research definitely is kind of mixed in this area. But I do think that if you talk to many people that have been going to AA meetings and to recovery-based meetings for a big part of their life, most of them will tell you that this rock bottom moment, whatever that might be, is another kind of big part of their own personal kind of recovery journey. And so I do think that it's important to just kind of point that out. And again, I have no idea how to model it. I have no idea how to incorporate it. But I do think that it is something that, at least on the recovery side of things, like as a person in recovery, it is very important to people in recovery. And so I just wanted to put that in there. And hopefully I'm not monopolizing the conversation here.
Oh, of course not. No, Noel, do you mind if it's what language like that, hearing that story, that, someone would say, oh, this doesn't exist. When we hear people in treatment and in recovery using this phrase constantly, like, oh yeah, that doesn't exist. That's not a thing. It's just so disheartening as a researcher. It's like, yes, it does exist. Yes, people people term it that way. Maybe we need to figure out as researchers a better way to operationalize it, that it works with in our paradigms, but it exists to people. So you can't just say like things don't exist. Sorry.
I guess that kind of goes to the second question, and I don't want to jump what John has to say, but balancing generalizable mechanisms of recovery versus individualized ones, and how to strike the right balance. But John, maybe you wanted to add something to the previous point before we move on to
point, and I guess I can connect the latter one to where you want to go. And first, moving back to what Brenda said and Warren said, I mean, I think if we're going to do measurement over a long period of time, we need to think, obviously, and we all know about the burden aspect of it. And so certainly things that place more assessment burden on individuals are going to be harder. But I think we have to factor in the benefits of measurement as well. And we monitor people using various forms of sensing for up to a year, and we retain them really well. Some of what we're monitoring is very passive. We're monitoring geolocation, we're monitoring cellular communications, and so it doesn't take much effort. But we also do ecological momentary assessments, pushing out surveys 1 to 4 times a day, depending on the protocols. But we frame this for individuals as a way to help them self-monitor. And when individuals take on that perspective, they actually see value. We have individuals asking us to feed back their EMAs over their study period to them so that they can detect patterns between their own experiences over time. And we also ask people to say what would they be willing to do and how much more would they be willing to do if there were direct clinical benefits. I mean, we're in the business of building prediction algorithms, but we're not predicting live with individuals right now. And what our participants say is they would provide even more data to us if signals were fed back to them that were of use to them. And so I think figuring creatively how to make assessment have benefits as well as just study the processes that we're studying is a way to get people compliant and kind of bought in over much longer periods of time. And then maybe to try to transition to where you're going. As we're talking about modeling, I think it's really important, and I take this from, I mean, I'm a machine learning guy, and I take this from the idea of, are we building explanatory models or are we building more prediction models that have utility? And I was a laboratory psychophysiologist for many years in the explanatory domain, and I shifted out of that because I became dissatisfied that most of the constructs I was measuring accounted for very little variance in the behaviors I cared about. Like, so we could find, significant predictors of insert outcome that you care about, but they didn't account for very much variance at all in that. And it wasn't really until we started to do much more high dimensional, so dense measurement of proximal factors and prediction models at the level of the individual that we started to be able to have some precision in understanding when things would happen. And we can predict goal and consistent use at very high levels of, I mean, not accuracy, it's more like, area under ROC curve, but for general terms, really highly accurate at the level of the individual. And I think most of us with our explanatory models never move beyond population-based models that when you try to apply them to everyone don't work well. And so that's where I was saying, like, the idea of focus on the individual and dense measurement of proximal experiences of the individual, I think, are critical if we really want to understand what's going on for people.
I think I think that's a great segue into the second point, which is, what is the reasonable or the right amount of complexity that we should expect from models of recovery? But I think what you were describing also has this other challenge, because even in the domain of predictive models, are there current approaches that are sensitive to time scale? Is that Is that like how time varying predictive models, do those have their own challenges? Is that something that you can recommend?
Well,
or ways of doing it?
It depends on what you mean time scale. And the work that we're doing, again, a lot of our work is about predicting goal and consistent use. And we can handle time scale in a few ways. We can predict into more and more precise periods. And so we can get, if this is worth it to people that know these metrics, area under the research, area under RFC curves of 0.9 and above, predicting episodes of goal and consistent use in the next week, in the next day, in the next hour. We can take those week models and we can lag them out 2 weeks into the future, so we can predict with real high accuracy whether or not someone will engage in goal and consistent use now into the future. Our motivation for that is to allow people lead time to do planning, to gain access to the support they need to intervene before those problems emerge. And so, like, there's those time scale issues on, I guess, on the outcome end. On the feature end, on the predictor end, we find much more success predicting with proximal rather than distal predictors. And so we've been struck by, if you use kind of the classic addiction constructs that we've all focused on, addiction severity, withdrawal severity, all of those sorts of things, they don't predict at all.
Nope.
not the individual, you don't get anything out of them. But if you start to measure who have they been interacting with this week, and are those people that they identify as healthy individuals, healthy for them in their recovery, or do they detract from their recovery? What sorts of experiences have they been having? Are they more stressful? Are they making time for pleasant activities? If you look at that over the last couple of weeks, you can get a lot of traction. And then to your point about how to handle the time varying piece, with us, a lot of what we do is, you can measure absolute levels of whatever these features are, but you can look for change over time within the individual, looking back for, okay, well, for a long period of time, their social network, they were spending lots of time with individuals that they reported were, supportive of their recovery. But now we see that going down and more time going up with individuals who they identify as less supportive. And so it's not just the absolute level, but change over time. And so you can easily model that at the feature end of these models as well. And that's where we get most of our traction for doing good prediction.
Mm-hmm. So in the idea of individualizing these predictors, do you see this, or the panel sees a good opportunity for what was brought up earlier, things like open-ended natural language processing methods or idiographic methods, incorporating metrics that are collected outside of the clinical setting? I mean, you mentioned some of those already, and how people socialize in their environment and so on. What do you think is the role of these methods and in the individualized prediction? And there's some hands up, Lauren, and then Brenda.
My comment was actually far removed. It was a little while back, so I'm not sure if it's going to be relevant. Would you prefer to stay on topic and then you can circle back around to me?
Yes, I think we can come back to it just to make sure we get to all the points we wanted to touch on today, if that's okay.
To give John a shout out of what he just said, I will say that everything I measure, all of my significant findings of either forecasting or predicting is never in the clinic. Like I don't even know if I should call myself a clinical researcher, because I'm never in the clinic. I'm measuring what their lives, their mood, what they did last week. I'm measuring their social media language for the last 5 years retrospectively, and all of that. It's like, it goes into making the sausage, and it does a great idea. It gives us great predictive ability, or able to predict out what's going to happen or where that person is at. And I think that when we talk about, we always try to beat income, race, gender, because of the social determinants of health. And just so much of what a person experiences day to day is tied up into the systematic system that we have. So our view is, if we can beat those things in the model, we're doing okay. And that's another thing, is like, when we build our models and we're building the environment for most people, which or using drugs or in recovery or whatever, you know, it's built with so much systematic issues that it's really hard, I think, to tease that out. And I think that is what we heard from people last week about the lived experiences too. So, sorry.
Yeah, definitely. John and then Marinia.
You're muted, John.
John, I'll come in afterwards. I've spoken a lot recently.
Well, I would just, to confirm from what I had noted earlier, when we had incorporated not individual level SDOH, but community and regional level SDOH that operate at different levels, we did find a lot of additional information when combined with individual level and surveys. So that the individual, it added a whole additional level of structures that would have been completely missed if you had just focused at the individual level. So as far as for moving the science forward of what are the social determinants of health, like theoretically, conceptually, I think we still need to think about population level factors because otherwise we kind of, you know, it starts to shift back towards this individual personal level of responsibility that I think can be kind of problematic in many ways. So the individual level recovery is essential, but within the context of structural levels or structural level factors that are operating at this wider level that can be influenced. And just to note that only a small percentage of folks who make it into a clinic to access treatment will be in these predictive models and other types of models, right? You're not getting all the folks who maybe wanted to get treatment but couldn't find it or passed away before they reached it and that sort of thing. So I think that we also have to think about like the upstream process of that recovery and you know, brainstorm different creative ways to start to fold that in as well.
What about a little bit of a mixture of both, where you have the individual data, you know, the environment that a person lives in, visits, frequents, you can incorporate that in either at you know, different periods of time points into the model too.
I think you still get the challenge though of then you still, not everyone, like you still have a sample bias of the folks.
Oh yeah, we're going to go into the bias that's coming up. That's a couple of questions.
For sure. Yeah.
Warren?
Yeah, so the way we've been tackling some of these issues is using standard techniques to identify profiles of what people in recovery look like, right, into different subgroups. And then we see whether those subgroups are stable and do people transition from one of those seemingly stable subgroups to another one? And what are the occasions that, you know, what can we detect that may be related to that? It's maybe fits in between the group and the individual.
Yeah, that's a good point. John?
Yeah, I mean, I guess to connect back to what Marinia was just saying, I actually wasn't advocating against system level measurement as well. I guess I was, I found less power in individual broad constructs that aren't about proximal experiences, and I definitely see the value in understanding the individual within the larger system. And then to the qualitative piece, I don't know that it's fully qualitative, but I'll say, you know, whether or not we're working with location data or communications data, I think it really is important to get the individual's personalized assessment of what, you know, of the spaces and people they're talking to. I mean, you can imagine doing, you know, natural language processing on a series of text messages, and you see a message saying, "I had a really hard day. I really need a drink." And that text exchange and the, you know, the response is, "Come on over, I can help." And that response is with someone who they've used with in the past versus their supportive mother. And so understanding who they're discussing who they're generating this language with, or what the meaning of this space is. You're going out to a space regularly, and that's a space that you believe is a risk factor. And in many instances, we're asking individuals to code places that we see them go to frequently for their own experiences at those places. You can get some things out of public data. This is a bar or a restaurant or something like that. But a lot of the meaning comes from the individual. And I think we have to synthesize that back in when we do sensing of this stuff to really make them powerful.
Maybe Juan and then Warren.
I want to follow up with the prediction because recovery is very hard to define. Then to me, it's very hard to think about the outcome. It is multidimensional, right? It has health, social relationship, your quality of life. So I think treating it as a prediction problem without a clearly defined outcome is challenging. And then individual factors, their effects were moderated by the community level factors like social, environmental, or your neighborhood characteristics. So I'm trying to think about whether this is a prediction problem, rather we should think about the profiles, how the different trajectories of different individuals across those multi-dimensions change over time, and how different factors moderate each other across multi-levels and across time.
Yeah, Warren, did you?
No, I'm good. Thank you.
Oh. So maybe this already came up to some degree, but we didn't explicitly touch on it. And it's about this subjectivity aspect of recovery. How do we capture this in our models? How do we capture subjective experience or perceptions of recovery? And should only subjective benchmarks be considered, or do we combine them with objective ones, quantitative and qualitative measures? What are the best models to capture this aspect?
Well, I can tell you what we do. We ask people to define the start of their recovery as the first sincere effort that they made to change their substance use issues, regardless of whether they're successful or not. And then thereafter, we measure and report on remission status, DSM, quality of life measures, World Health Organization quality of life scale, and a couple other measures to sort of track these different dimensions over time. We ask people just when they initiate recovery, not
as they're
are you
moving.
recovered or what's your definition of it.
Mm-hmm. So it sounds like you would advocate for modeling these together, but maybe not at the same, maybe they're not as informative in the same time points, or we don't have information to say currently.
So I'm just not sure, like, at that point, so we have a benchmark of when everyone starts. Trying to figure out if it's subjective, and I agree with the large group, it can be. Trying to parse that for research purposes is an interesting problem, but it sounds like